So thank you to everyone for coming this afternoon. This is our first forum for 2016, and I think most of you do know me, but I'm still living out because I'm the program manager for the PCRNV, and I'm quite excited today. So it might be a bit, we're actually doing our first webinar. We tried it last time and the service broke down. So we have over 50 people joining us by webinar today. So if you can bear with us, we will have time for questions at the end of Sean's talk. So you can type them all up and we'll try and systematically answer them as much as far as we can. We won't over time Sean. So, and we're very privileged to have Sean Morrison today. He's taken time out of his very busy schedule to join us. So I've stalked you on the internet, Sean, to say you're the co-deputy director of the Jane Patty National Palliative Care Centre in New York. That's correct? Yes, correct. And the director of the Hertzberg Palliative Care Institute in Mount Sinai School of Medicine. You're dedicated to improving the care of persons with serious illness and their families and enhancing knowledge of basic palliative care in the United States. Your current research focuses on improving the management of pain in older adults and on developing evaluating models for palliative care delivery in hospitals and in the community. I can go on. You're an active clinician and you've had numerous awards. Some include the American Academy of Hospice and Palliative Medicine in 2010 and the 2013 Excellence in Scientific Research Award. And you have received over $45 million in research funding and published over 125 peer-reviewed papers. So please welcome Sean Morrison. Thank you.
So first of all, thank you so much for inviting me to speak. I think I was telling folks the last time I was in Melbourne was in 1972, and it did not drop below 40 degrees for the 5 days that we were here. So it's really quite wonderful to come back, although I guess yesterday reminded me of those early days in Melbourne. And also, we've had the opportunity to spend 3.5 weeks traveling around Australia, and it's just been absolutely magnificent. So it's going to be very hard to go back on Saturday. So what I wanted, I think, what I'm going to do today is talk a little bit about how two centers in the United States have used research, and particularly health services research, because that's the bulk of what I do these days, to help build the practice of palliative care and palliative medicine in the U.S. And I want to sort of bring all of you back to the turn of the century in the United States, where we had seen a number of very, very significant challenges facing us. First of all, we had seen really an unprecedented gain in human life expectancy, where we'd seen, say, 100 years ago, the average age of death was 50s, 60s. And childhood mortality was the norm rather than the exception. And now all of us expect to live into our 70s, 80s, and 90s. And we've seen the cause of death change from acute infection to chronic disease. We have had it now around 2000, about 10 to 15 years worth of data that suggested that people living with serious illness have a multitude of untreated physical symptoms. And their families had a tremendous amount of unmet need. And as my colleague Diane Myers said last night, in the United States, the #1 cause of personal bankruptcy is being a caregiver and healthcare costs in the setting of serious illness. We have an entire generation of untrained healthcare professionals. As you know, in the U.S., you go to university first and then you go to medical school after that. So when I graduated university in 1986, I went to the University of Chicago, one of our relatively good medical schools in the United States. Spent 4 years at the University of Chicago, went on to do 3 years of internal medicine training in New York at New York Hospital Cornell Medical Center, then another 2 years of a geriatrics fellowship, another year of research, and in that 10 years of medical education, had one 30-minute lecture on pain management, which occurred during my first year pharmacology course and dealt with how opioids are metabolized in the liver and excreted in the kidney. And when I was sitting beside, the bedside of a young AIDS person in 1992 in New York who had intractable pain, recalling that information was not terribly helpful. And up until the passage of the Affordable Care Act, we had a completely fragmented, unresponsive healthcare system, which is marginally better right now, I must admit. So we had a number of challenges. And yet, in 2000, we knew that palliative care offered a solution to a lot of the problems that we were facing. If you think about it, around the turn of the century, we already had some fundamentally good data that demonstrated that palliative care could improve quality of life for people with serious illness. We had by then a meta-analysis, several meta-analyses that demonstrated reduced pain and other symptoms, and that palliative care helped match treatments to patients' goals. We had by then a number of very good studies from this country, from the UK, from Europe, from Canada, and even from the US that demonstrated improvements in family satisfaction. And we were beginning to understand that palliative care might reduce healthcare costs. There was this idea that providing the right care to the right people at the right time reduced healthcare inefficiency, and obviously by treating people in their homes rather than hospitals, that also could have an impact on healthcare costs. And yet, if I bring you back to the States around 2000, about 10% of U.S. hospitals actually had palliative care teams. Nobody in the country actually could define what palliative care was. If you went to the average person on the street and said, what is palliative care, you got a blank stare. And most clinicians throughout the U.S. felt that, you called palliative care when there was absolutely nothing else that could be done. We were the service of absolute last resort. So, about 2000, a lot of people in the U.S. began thinking about what is it that we could do to improve care for people with serious illness, and what would it take? And if we think about what characterizes a successful intervention, there are a number of key factors that we know from the management research that are absolutely necessary. First of all, any intervention has to show a relative advantage. That is, how much better is the change going to be? And I would suggest to you that in 2000, even by the late 1990s, we had good data that suggested that people with serious illness with palliative care would be better off. It had to be compatible. It has to be compatible. Can it fit in? Can the puzzle piece fit in to the existing framework? Can it be the missing piece rather than having to put together something separate? And again, we had models, not so much in the U.S. for hospice, quite honestly, and I think Diane Myers talked about this, hospice is actually a really separate system of care. It sits outside mainstream medicine, which is why less than 50% of Americans actually receive hospice before they die, in many respects. So it had to fit within, and palliative care did that. That could be really simple. And what's more simple than saying we're a specialty that improves quality of life in the setting of serious illness? We improve pain and other symptoms. People get that, right? And this is where I think we were, particularly in the States around 2000, was can we pilot test it? So we had a number of different programs setting up that were demonstrating success. Can we observe the benefits and can we measure them? And I'm going to talk a little bit about how we did that. And then once you do that, is it scalable? Can you take it from one place and move it to the other? And I think most of you know these sort of stages of social change. These have been developed for a long time. But this idea that there are 5 stages of change: pre-contemplation, this idea that the problem exists but nobody's doing anything about it. That was the late 80s, 1990s. Contemplation, people were starting to get it in the United States. That was the mid-1990s. That's when our first area, 2 things happened in the States in the mid-1990s. One was euthanasia, and suddenly the euthanasia movement became real for us, and we got very scared. Were things so bad in the United States that people were opting to end their life rather than continue living? And we had what's called the support study, which was a study of 9 of the best American hospitals that just demonstrated appalling care for people with serious illness. You got to be prepared for change, and I think this is really where we were around 2000. That we were beginning to think about how could we prepare for action, and obviously you got to do something about it, and then once you get there, you got to maintain it. So the other thing that I think happened, or we began thinking about early in 2000 is sort of illustrated by Hyman Rickover's quote. I know I'm down here. Does anybody know who Hyman Rickover was? Rickover was the father of the modern American submarine navy. So he was the person who basically developed the modern nuclear, that is in propulsion, U.S. submarine force. Quite a character. And what Rickover said is that good ideas are not adopted automatically. They must be driven into practice with courageous patience. And again, we've all seen this, right? There are thousands of good ideas, but what makes a good idea move forward into actual practice? And what needs a good research idea? What takes that into an effective change? So what I want to talk about today, and really sort of the last bit of this talk, is to use a case example about the development of U.S. palliative care that really sort of highlights the work of 2 centers. The Center of Advanced Palliative Care that I think most of you met Diane Meyer earlier. So Diane directs the Center of Advanced Palliative Care, and then its brother, sister, partner organization, however you want to put it, which is the National Palliative Care Research Center, which I direct. And what I'm going to talk a little bit about is how we've sort of taken these 2 centers and work synergistically to use research to promote change in the U.S. Does that make sense? And feel free to interrupt with questions. So very briefly, let me tell you about the 2 of them. The Center of Advanced Palliative Care, or CAPC, by what it's known by, it's a national center. Its home is at the Mount Sinai School of Medicine in New York, and it's supported by private sector philanthropy. Diane goes out and basically raises money for their budget up until this year when they became an institutional membership organization. It has a very specific audience, and I think this is really critical. It's about audience-specific messaging. And the audience for CAPC is hospitals and health systems, clinicians, and policymakers. That's who their whole focus is around. And the focus is around the dissemination of the evidence base of palliative care to hospitals and health systems, essentially to promote the development of palliative care. And its products and how it does that is through a diversified portfolio of practical technical assistance products that help you essentially start and develop a palliative care program. It's the cookbook. It's the joy of palliative care, for example. It's the how-to. We conversely are a wonky research center. We are also, based at a medical school. It gives us some credibility, and it also serves as our philanthropic base. Our audience is really different than CAPC's. We are focused almost exclusively on academic institutions. That's where knowledge develops, researchers, and to a certain extent policymakers, and particularly now that there appears to be more of a budget for research in the United States, more and more focused on policymakers. But we are not focused on clinicians, and we are not focused on administrators or on practitioners. We have a very narrow audience. And our focus really is on the development of that evidence base and a research infrastructure. Because back in 2005 when we started, I could count on one hand the number of palliative care research institutions in the United States that if the director or the head left, would survive. For example, at Mount Sinai back then, if I had left, there would be no platform anymore. So our goal was to really create that type of infrastructure that would transcend the loss of a leader. And our products are very different. We give out research grants, career development support, technical assistance to researchers. So we provide, for example, consultations in research design, methodology, statistical analysis to anybody throughout the United States who wants to apply to us for that. We have an ongoing series of webinars focused on advanced research methods that are specifically focused on palliative care. And we do grant peer review. So if you want to submit a grant, for example, to a federal agency, you send it to us and we'll put an experienced reviewer on it and pre-review it for you. So it's very specific technical assistance products. And we bring researchers together on an annual basis in a research symposium. And we've got a shared vision, which is that all seriously ill patients and their families will have access to high-quality palliative care. And that's why both of us exist. And I think, and I'm going to show you examples of our success in a minute, and I think there were some three keys to what our success was. And the first, and not to sort of belabor with, was that we are not the audience, we being the field. And that our messaging and our approach and our integration into mainstream medicine really required us to speak that language. You know, Woody Allen, this idea, and I think Diane has talked about this over and over, and I don't, but this idea that people have an abiding desire not to be dead, and that leading with end-of-life care language, particularly to our academic audience and our researchers, was a non-starter because people kept saying, well, that's not us. That's not who we take care of. The gastroenterologist would say, that's not who I take care of. Cardiologist would say, that's not who I take care of. So this fundamental shift from improving care of the dying to improve quality of life with people living with serious illness guaranteed us a much broader and more sympathetic audience. And I don't think it's disingenuous, because if you improve quality of life for people with serious illness, if you do that, the end result is going to be a better quality of death for everybody, because everybody is going to go down that pathway eventually. But this was critical in our messaging, particularly at the National Institutes of Health, who kept saying, we don't do end-of-life care. National Institute of Heart, Lung, and Blood, we don't do end-of-life care. Go to National Cancer Institute. National Cancer Institute, we don't do end-of-life care. We're focused on curing cancer by 2015. That was their mantra. We didn't quite make it. Go to the National Institute on Aging. NIA said, we don't really do end-of-life care. We're focused on improving function, as if when you get to 99 or 100, you're going to go on to 110, 115. And, the other big piece was, this was the front page of Newsweek, the case for killing Granny. That was not a good soundbite for us, by the way. So one of the keys was shifting the message, and this is part of the American Cancer Society's new ad campaign for palliative care, and that's what's in the bottom here, is the definition of palliative care. They've got some great ads along this one. So the first was we weren't the audience. The second, and I think this has been very hard for some researchers, and I remember having a very strong debate with a healthcare economist about what is the role of a researcher. And it is my belief that a researcher's responsibility really begins with the journal publication. That's not the end. That is the beginning. And I say that as somebody who takes public money through our federal funding agencies, that I take taxpayer dollars to do the research that I do. And so I believe that I have a fundamental responsibility to the taxpayer to make sure that the work that I do goes beyond palliative medicine. Because the reality is the people who do the work that's going to improve patient care don't read palliative medicine. The administrator of my hospital, my senator, my president, my congressperson doesn't read that journal. And so that creating change and influencing policy or moving research really into the practical domain requires really audience-specific messaging, that you've got to take the research and make it relevant to the public, to policymakers. But you've got to use the media effectively. I mean, I used to be terrified when a reporter would call to talk about my research. And I would do everything I could not to talk about it. And actually I was taught, don't talk to reporters because they'll just mess up the message. Now if a reporter calls, I will drop everything to talk to them because I've had media training. I'm comfortable talking to them. I know what the message is, and it's an opportunity to reach the public. That's education, just like anything else. And it requires practical technical assistance, that you don't come out of the womb or you don't come out of a fellowship being a senior researcher. You need help, and particularly in our field where we don't have big, huge centers with lots of people, we need to have centralized technical assistance. And then this other idea is that what we call the value equation in the States, which is simply quality over cost, that the value equation has both a numerator and a denominator, and that we have in the field been really focused on the numerator. That is the impact of palliative care on quality. But if we don't think about the cost, and if we don't think about research that focuses on cost, we're not going to see widespread dissemination and adaptation. Because there are a lot of good ideas out there that cost a lot of money. And in my country, or my adopted country, we don't have a lot of extra dollars to pay for new bright ideas. So we had to think about that. So we have what we call both a top-down and a bottom-up strategy towards influencing social change and using research. The top-down is to create a supportive environment through talking to the media, through accreditation, through policy, regulation, payers, research, and education. And then a bottom-up, which is to develop the evidence base, to increase the number and quality of palliative care programs and researchers, and to provide the technical assistance that aids the top-down. And you can see they both reinforce each other. So let me give you two examples. The first really focuses on the top-down approach, which was back in 2000, or actually 2005-ish, we said, this is where we are in the States. We need to create demand for palliative care. And how can we do that? And specifically, we wanted to increase the prevalence of hospital palliative care teams. Our strategy, or was to create an ongoing local demand. Is how do you create demand and how do you create attention? And one of the ways that we thought we could do this through health services research was to really begin to examine statewide variation in access. Because what do people hate? Variability, right? I mean, and you really hate to be compared to somebody else, right? We also felt it was critical to identify what were the factors associated with the development of palliative care in a very diverse healthcare environment in the United States. What was it that allowed palliative care teams to develop in some parts of the country and in some cities? And why was it that some other people were behind? Because what that would do was it would give us a roadmap as to how we would seek improvement. And it would allow us to create ongoing benchmarks. So what did we do? Well, we've had a series of reports, research studies, that have examined over time access to palliative care in the United States. The first was by one of my medical student researchers. That's in the top right. There was a second published in JPM. The most recent was done just this past summer. And when I looked at this back, I guess about 4 or 5 months ago, these papers have been cited 200 times, which is, an academic is not too bad, right? And they've been downloaded, now it's closer to 9,000 times. So 9,000 people have actually downloaded one of our manuscripts. That looks great on my CV. And when it's coming up for promotion, that looks really, really good. However, it doesn't really help, right? Because I'm responsible for about 8,400 of those downloads, and my dad's responsible for the other 5. And I keep citing myself, so that's about 150, right? So what did CAPC do with these data? And remember, their audience is different, right? What did CAPC do with these data? They did a couple of things. First of all, this was an ad that was taken out in the Washington, i.e. down in Capitol Hill, major newspaper that all the politicians read. This went into Politico, highlighting the states that did really, really well. For those of you who may remember, Bernie Sanders is running for president in the United States. I remember riding the Capitol train, this little tram that goes between the Capitol and the Senate office buildings, with Bernie Sanders from Vermont holding this up to his colleague from Rhode Island in the set tram behind him. That made a difference. It made a difference. We also published a report card that was slick. It was glossy. Had lots of pictures in it. And not only did we put it up on the web, but we mailed it to every single governor in the United States so it landed on their desk. It cost us 52 things in postage. We did a Capitol Hill briefing. So in partnership with the Patient Quality of Life Coalition and the American Cancer Society, we did a briefing down on Capitol Hill. So we went down to Washington and talked to people about this and brought a patient, Christina Savasta, my patient. Those of you who were at the session last night saw Christina's photo. And you can download the report, and if you want to click on your state, you can actually find out what palliative care looks like in your specific town. And we put this, these are data from the last report card I did. We targeted the media very specifically. We targeted the national media, so it came out in Forbes. We targeted the local media, and I love this one. How to spin bad news into good. Alabama gets a D, but the University of Alabama is way above the curve. Over 10 million Americans saw those headlines about palliative care. And it was a very clear messaging strategy that went hand in hand from our research center with CAPC to be able to sort of think about what's the main messaging, what do we want to communicate, and how are we going to communicate it. And it was a lot of work connecting with the reporters. It wasn't about just sending in a press release. So that was example number one. Let me talk about example number two. Again, this idea about how do we increase the prevalence of hospital palliative care teams. Remember I talked about the numerator and the denominator. Well, this was focused on the denominator, which was, could a business case be developed for palliative care in U.S. hospitals? And remember, we are working in a very dysfunctional healthcare system in the U.S., so there's a lot of opportunity for savings. We thought, again, our hypothesis was that palliative care should be cost neutral. You've got to pay for an extra team, but by getting people out of the hospital, reducing unnecessary drugs, ICU stays, tests and treatments, that we would be cost neutral. So we wanted to identify and quantify what we actually thought were costs, not cost savings, that palliative care programs could do. We worked with some healthcare economists who, right around the time that we were doing this research, there were some really new and exciting methods about using analyzing observational data, propensity scores, instrumental variables, that hadn't been used in palliative care research. They've been used in other areas. They hadn't really been used in medicine for the most part, but they allowed us to do what others hadn't been able to do, which was take large observational data sets and begin to analyze them and mimic randomized controlled trials. We wanted to provide normative cost data for hospitals, and we wanted to look at whether these cost savings applied across different payers in the U.S. Medicare, which is for people over the age of 65, Medicaid, which is a system of care for the indigent, the VA, which is our separate system of health care for veterans, and within the hospice, which is a separate carve-out under our Medicare program. So we actually had a number of different publications. This was the first, which was an 8-site study we published back in 2008. Subsequent study published around Medicaid. Did I put the others in? No. We did one in the VA. We did one with hospice programs. We've recently published 2 that have been specifically in cancer, that have been in Journal of Clinical Oncology and Health Affairs, all of which is still exactly the same. and almost the same data across these systems, that palliative care dramatically reduces expenditures for hospitals. Not is it cost neutral, it is dramatically cheaper. On the order in US dollars of a big $2,500 per admission per patient. So again, my dad read the health affairs paper. Actually, my dad read the abstract from the health affairs paper. And I think a couple of other people did. So what did CAPC do with this? CAPC took those data, all of those, wonky scientific publications, and put it into a 5-page, 4-page brochure directed at hospital administrators that had lots of colors, very, very few words, and could be read literally in 2 minutes. And when I was at the University of Indianapolis in Indiana, meeting with the CEO, handed him this. And when I had left for that, after that site visit, he had charged the entire system with developing a palliative care program. I mean, it's because he could read it. And there were data backing it up. We took all of that complicated statistical analysis and made it really simple. So it was a cookbook about how do you build a program. Building a business case, and on the right, you can sort of see there are a series of Excel spreadsheets. And so what any hospital in the United States can do is download that spreadsheet, put in their data, how many patients they see, the percentage of cancer patients, their length of stay, and push a button, and they will see what their cost savings are for their hospital and what their estimates are. And they can vary it, so they can make it very conservative or very optimistic based upon 5 national studies. So that we made it really easy. So nobody has to reinvent the wheel and say, I don't know how to do a propensity score analysis. I don't know what the instrumental variable will be for my specific hospital or my program. And how the hell do I analyze these reams and reams and reams of patient data? Well, we've done that. So again, this idea of a technical assistance in translation. We had a very specific media outreach for this, and it was almost exclusively to the business press. Because what I didn't want on the front page of my home newspaper was palliative care cuts costs on the back of the dime as the headline. That was not. So we were very careful. And we were reasonably successful. Cranes, Forbes, Reuters, Modern Healthcare, Politico, and the headlines and the message was actually pretty good. We didn't see that, we're going to cut your costs by cutting care headlines. And the question is, did this have an effect? I think it did. When we look at the growth of palliative care in the United States, I talked about, turn of the century where, 10 to 15% of people have programs. Up in 2014, 2/3 of all American hospitals have palliative care teams. But the more important statistic for us is that 94% of our mid to large size hospitals have palliative care teams, and they take care of, those larger hospitals take care of about 3/4 of Americans. So that we almost have somewhere universal access. And when we look at our teaching hospitals, which is where the next generation of researchers, the next generation of clinicians are coming from, 97% have palliative care teams. And 74%, as I said, of Americans now who die in the U.S. have access to a palliative care team at the end of their life. And again, I think that certainly we were not the major contributor to this, but I think we were a significant step in getting to where we are today. And our map in the U.S. looks a lot better. If you live up in Bernie Sanders' area of the world, which is up in the right-hand corner, over 80% of hospitals have a palliative care team. We got some work to do in the South. The South in the U.S. is really different. We've got some work to do in the South. But the map looks better. We have no D states. We have no F states. And on average, the nation has a B, which is pretty good from where we were 10 years ago. So how did we get here? And what was it that I think led to change in the U.S.? First of all, it needed data. It was critical that we had the evidence. And it was critical that we had the research along three areas. One is palliative care improved quality, address patient and family preferences, and it helped hospitals, hospice, and healthcare systems meet their fiscal pressures. It needed technical assistance. It needed an organization to take that body of research and translate it into practical technical assistance products. And I think what has worked really well for us, again, is the focus on different audiences. And that we have not tried to be one thing to all people. And quite honestly, our communities are different. I would love the academics to talk to the practitioners. I'd love the researchers to talk to the clinicians. The reality is that is a lifetime of work that we haven't done a really good job at. And we chose to be very pragmatic and essentially talk to the two of them separately and bring it together for them. And we have really focused on targeted and strategic media outreach so that each one of our papers has clear messages and sound bites around this message of improving access to quality palliative care in the United States. In each of the sound bites, each of the messages that we put in come back to that, so it's really straightforward and simple. And we train our researchers. At the NPCRC retreat, we do a whole session with our young folks on media training. We give them the skills to talk to the media. So they know how to do it, including what to wear. And yet, I would suggest to you as a research community, we've got a lot of work to do. This is Christy Ulrich's paper that looked at characteristics of fatigue experienced by children in the last month of life. This was this came out in the presentation by our carer last night at Last Needs Forum, that the overwhelming symptom of kids is fatigue and being able to get out of bed. And, if you look at, the patient report of high suffering, treatment, okay? But if you look down here, the reason given for no treatment of fatigue was no available treatment available in over 50% of the cases. We need to do better than that. We need as researchers to give our clinicians the data and the evidence to be able to improve care. And just to put it in stark reality for you, this is work by Laura Gelfman at my shop, where she simply did Medline searches on the volume of research published in oncology. And folks, this is limited to English-speaking studies in human beings that are clinical trials. So it's not even the animal data versus what we published in palliative care over the same period of time. Into period 3 to 5 and the recent 2008 to 10. And the good news is, we've quadrupled the number of palliative care publications in that time. The bad news is we're still less than 1/10 of what oncology is publishing on a routine basis. And this is where, as I said, we need to be active on the policy front, both as researchers and from our patients and providers. Because when I look at the National Institute of Health, and again, this is Laura's work, 0.2% of NIH dollars, our National Institute of Health dollars, focus on palliative care. And as scientists, what is 0.2% round to? 0. I mean, if you look at NCI, our Cancer Institute, 0.4%. That's not 4%. That is 0.4%. And this is NIH, the National Institute, does not respond to scientists who say, give me more money for my research. Because I got to tell you, the cardiologist is saying the same thing. The oncologist is saying the same thing. This is where we need to be working with our clinicians, with our policy groups, and our patient and care organizations, because they're the ones who are going to speak to the government, who are going to change how the funding is allocated. Because within the scientific community, we form a perfect circular firing squad, right? You know, with one pot of dollars, everybody are fighting. And we're not going to stand up to the cardiology and the oncology groups. They're much, much bigger. But our patients and our carers can. And I know I'm 2 minutes over, but give me 2 minutes. And I think we really need to move beyond this idea that our palliative care evidence base is provided by data from other populations, by results from small series of patients, and God forbid by anecdote and hearsay. I mean, I still see patients and I still practice, and I expect you guys have the same thing where you're stuck. You've seen something you've never seen before, and you try something that somebody said, you know, I've tried this in this person and it worked. God forbid we should be practicing medicine like that because it's the only thing we have. So what do we need? And I think this is my last slide. First of all, we need legislation and regulation. And I think we're not going to be able to be effective as a research body unless we get the funding to do that. And that's going to require development. It's going to require coalition building so that we speak with one voice. We, at least in the States, we as a group shouldn't be the circular firing squad. I mean, when palliative care, when I go down to speak to my representatives from New York, I should be saying the same message as my colleague from Boston about the same priorities. And so for the most part, we've done that. We're starting to do that. But it means building coalitions with folks outside our research community. So one of the best partnerships that I have had has been with the American Cancer Society's lobbying group. They get it. They're the ones who did all the public awareness campaigning. They meet with legislators regularly, and what they're advocating for is legislation to promote palliative care research. But they do that much better than I do. And that's been a partnership that's taken 10 years to build. And we need public support. I mean, we should not have carers saying to us, you know, and I remember this from yesterday, that his pain was so bad we couldn't take him home. We had to bring him into the hospital. We had to have a syringe driver, and God knows what we would have done without that. Shouldn't we have the evidence base to be able to say, you know, we had effective medications that could take care of him? We have something that's, I mean, it is amazing to me that right now opioids are still our gold standard, given everything we know is difficult about them. And we don't have a bit. Imagine if Aldermet was still, for those clinicians, was still our antihypertensive drug of choice, right? We need to have, as a research community, we need to be the experts. And I think this is very important. We have to have our colleagues for the advocates. And I think it's very different to distinguish being an advocate from an expert. Because if we have our colleagues, if we have our clinicians who are the advocates, when we are called to testify, we can speak as the experts. These are what the data show. These are the implications of those data. And finally, we need to have effective communication as to why this is important. You know, what I train every one of my graduates, every one of our research young investigators, is they've got 30 seconds to tell the person on the airplane beside them what their research is and why it's important in language that they can understand. And we go through that exercise because they have to be able to effectively communicate why it's important. And as I said, not to beat a dead horse, but this does require collaboration. And it does require us to think about what are our individual strengths. We can't be everything to everybody. But it requires this idea about clinicians and researchers. It requires this idea about private sector philanthropy. It means working with organized medicine. And I think what I was blown away by is, which we don't have, is when I looked at the executive committee of your group, it's not palliative care folks. And that's pretty good. I mean, that's engagement. And I will close. I love using sports analogies, and I will bring you to ice hockey. Actually, last night I was thrilled because I turned on the TV last night, and the final for the Super Rugby from last year was on, which, you know, I never got to watch in the States, so I got to watch rugby for an hour and a half. But Wayne Gretzky is considered to be the greatest ice hockey player who ever lived. He's Canadian, by the way. And when Gretzky, somebody asked Gretzky why he was so good. And what Gretzky said is, I skate to where the puck is going to be, not where it's been. And I think for us, if we really are going to make a difference, we have to have a very clear vision of what we want, where we want to go, and we have to think really, really strategically about how we're going to get there, which is not what people in research typically do. You know, typically we see an interesting question, an interesting problem, and we go at it. I think right now in our field we can't afford to do that. We have to think about what do our clinicians need? What are the gaps in the data? How are we going to affect change, and what is the research going to be to do that, and how are we going to do it? And then, once we do that, I think we can go back perhaps to the old way of research, which is, it's a great little question, let me go get a grant and do it. I think as a field right now, we just can't do that. At least that's my personal opinion. So let me stop there. I know I'm over, sorry. So,
no, that's fine.
And you know, happy to answer questions, you know, deflect arrows.
So we're going to see how this works. I might stand here next to you. How the where's our?
Oh, I'm sorry.
No, that's okay. Right. Sorry. No, have we lost the webinar link? I can't see it.
Can we ask a question?
Yeah. Why don't we start while we? Why don't we start? Sorry. No. Go.
John, what you're describing is a very sophisticated, strategic approach to the whole big thing.
Yeah.
And I'm wondering, and it's too big for one person, and it's probably too big for one sentence to describe. But I'm wondering if, as someone who's an early researcher or a junior researcher, getting going, what would be the key issues for them?
Yeah. So let me answer that part second, because I actually want to tweak you a little bit about this. I actually don't think it's too big for one center. Because I think the key is somebody's got to fill that back. And I think what happens is it just feels like too big a problem. And the reality is you've got to start somewhere. And the reason that the MPCRC, our research center, got started was not so much that there were a whole bunch of people who thought this was a good idea and it came together. It was because a philanthropist in New York City said, what can our very small foundation do to help jumpstart research? So it actually came from outside. And they came to us because CAPSA was there and because we sort of had a track record and a couple other people applied. And said, can you do this? And I said, God, no. But once somebody said, you have to, we started small. We had the great fortune to be able to partner with CAPSA. And it was like that sort of the super saturated solution that all these researchers were looking for, just what could I do? And that helped us. It wasn't, you know, at the beginning it wasn't a big strategic plan. It was a strategic plan that was small and could make a difference. And obviously I'll be honest, giving everyone helps a lot. But that built loyalty. I mean, what that did was it built a very, very strong community. So coming back to your second question, what can early stage investigators do? I think there are a couple of real strong keys to success. And this is Morrison's bias. Morrison's bias is you are not going to be really successful in this field as an early stage investigator unless you're hooked up to a major program. It is just too hard to be working in isolation in a center in a university that doesn't have the early stage support of palliative care. I think it's just too hard. It's too hard to get funding. It's hard to get mentorship. It's hard to have somebody leading the path forward. And quite honestly, from my perspective, if you don't have a strong clinical program there, it's hard to figure out what's important to do. So my first, and people keep hearing that from me, but I think at the earliest, it's really important to be in the center. The second is it is critical to have supervision. It is critical to have a senior person who is going to guide you through the process. and get you access to the right resources and be able to really be that advocate for you and be able to think about that. And then I think the third piece is mobility. And that, I think, is what the center here does so well, is for people to feel like they're not alone. I mean, I think the feedback from our retreat every single year from our early stage investigators is, I came out of that reinvigorated because I know I'm not alone. That I've got an entire national community that is struggling with the same issues that I am, that are behind me, that are willing to help me, and I think that is key. And it doesn't have to be, I think in person once a year is really critical because you meet people, but after that, it's that email, pick up the phone, webinar. But just to know that you are part of a community, which in palliative care often feels like you're not because we're so new. I think it's critical for success.
Do we have another question? Can I? Okay, Phil. All right, go.
Hi, Sean.
Yeah.
I was really astounded in terms of the fact of how places such as the NIH, the tiny amount of money that they give to palliative care. In my head, I kind of thought, they must really fund palliative care. And so I've learned today that obviously you're backed mainly by philanthropic organisations. So I was wondering, what is it about these philanthropic organisations that want them to fund palliative care, whereas the government seems so averse at the present time?
So I think there's a couple of reasons. I think, first of all, when you're looking at federal funding, there's a fixed pot of dollars, and everybody's competing for it. And what we have not done successfully as a field in the states is get that lobbying around it. And that's where I think the American Cancer Society has been phenomenal. So I think that's part of the issue. The second thing is why philanthropists, why foundations, individuals? Because they get it. And I think, every single person has a relative with seriousness. I suspect your palliative care team is exactly the same as mine. Every person you care for feels phenomenally grateful for the care that they receive. And people who have money and people who don't have money, want to give back in different ways. So when somebody says, how can I help you? And I know that person is a multi-billionaire. I say, yes, you can help me. And what do you need? Well, we need financial support. And that is a very hard message for doctors to say to people. It is very hard. And I still have a very difficult time saying it. But the other hand is I'm the co-director of the J. and Patty Baker Center because Diane and I set that to J. and Patty Baker thinking we would get about $2 million US from them, and they gave us $5 million for each of them because we love it. So you don't get it, you don't ask. But I think that is the case. I think people understand that. Families who have lived through a serious illness and see how hard you are working to control symptoms. And then you can say, but your blood pressure is easily controlled. Well, that's because millions of dollars are searched for them by test research. So I think we have to be very clear and articulate about that message. The other thing that I think, which is extraordinarily helpful, is that at least at the NIH, one of the big barriers that we had is we didn't have peer review. So when you submitted a grant, it was reviewed by cardiologists, it was reviewed I don't know why you became oncologists, health service researcher who had no idea what palliative care was. So one of the strategies that we've really worked hard is to seed those review panels with palliative care experts. And we have succeeded with that. Now the three major panels that typically review the palliative care research have at least 2 to 3 palliative care researchers on them. And that's been extraordinary. And the other thing that we've done as our center is we don't give out big grants. We give out what sound to be really big grants in countries other than the U.S., but we pay salaries off our grants. But what we insist is those grants lead to, the purpose of those grants is to lead to federal funding. So, for example, we've given out $23 million. We've given out grants of $23 million since 2005. However, the return on investment from those grants has been 6-to-1 for development awards. That is, for every dollar we funded an early stage investigator, they've gone and down to $6 from the federal government, and 9-to-1 on experienced investigators. So if you do the math, we've given out $23 million. They have leveraged that to $150+ million in federal research support. So our goal of being a philanthropic center is basically leveraging $20. And again, it's that top-down, bottom-up strategy, right? The more people find NIH, the more palliative care research they want to see. So the excuse, well, I'm not getting grants doesn't fly anymore. It's putting the right researchers, the right reviewers on the review committee so that we actually get peer review and we get scores that are fundable. So that's the bottom-up approach. And then the top-down approach is getting legislation in to direct funds for palliative care research, which is what the American Cancer Society and others have done. It's meeting with the director of the National Institute on Aging, which is what I've done, and meeting with NCI so that palliative care becomes a priority. And last year, the National Institute on Aging put palliative care as one of the priorities. They're not a lot of money compared to everybody else, but it's now a priority. I know that's a long-winded answer.
No, it's a great answer.
But again, it's thinking about that in this strategic approach, which I never learned in this.
But that's really similar to us. I think 1% of our NHMRC grants less goes to palliative care research. Plus, we don't have the philanthropic funding, so we're just screwed. We have no money for research, so we're still recording something. Yeah, so we're very similar. We don't have the we don't have that sophistication to go and sell ourselves to donors just yet. But that's a skill we need to learn.
It's a skill. I mean, it's one that's really easy. I mean, of all the things that I've learned, it's a lot easier than media training because you're just talking about what's important to you. And I think again, to use this one big donor as an example, when Diana and I sat down in this very lovely room in the West with them, why was it that they were investing in us? It wasn't about the cost. It was, as Jay said, it was about your passion. It was about you guys. It was your passion. It was your stories. It was the commitment to patients. It wasn't about the technical systems. It wasn't about the risk. And I think as clinicians, as researchers, we can do that. Yeah. I mean, we can speak in that language. The hard part is saying, could you really give me some money? Please. But once you get the first grant,
And then next,
people say, I'm back in the winter.
Right, do we have a, sorry, we're out.
I have a webinar question.
Sorry, because it's technically not working here, so we'll read it out. We're going by text.
So we
Very quickly.
Point of time, so I'm reading out as it says, as you increase expectations and demand, how do you balance these with the limited available resources without having disillusioned and vulnerable patients and families when they don't receive that level of care?
With difficulty. Now, I wish we were that successful, that patients and families were demanding what we can't provide. But it is a real tension. And I think it's a tension that we are encountering right now in the States, and I'm feeling it in my hospital right now. And I think there are a couple of things that need to happen in order to address that. The first is, in this country, in the UK, there will never be enough palliative medicine specialists to provide palliative care, or even specialist level palliative care for everybody. So I think that really speaks to the idea of that core set of palliative care knowledge and skills being integrated within routine clinical care. And I think, as we've built the field in all our countries, we have been really appropriately focused on specialist level care. And I think we also have to be thinking, at least from I think about my survival and sleep, that as I should be focusing on much time as building the specialist level program as doing palliative care knowledge and skills training for the other people in my hospital, just for the survival of our building. So I think that's really key if we're going to meet demand. And then, our academic programs really should be doing that, teaching, research, and real specialist level care. At least in the States, we're still doing things. We're still providing care that I think could be provided by GPs and family docs and internists. We've got to get beyond that. So I think it's a bit of that level of education and moving into mainstream, which is hard. But that's going to be accreditation issues. I think it's too, as the business case, and this has happened with us, becomes stronger and stronger. It's working with administration to think about the right care pathways, the right quality improvement initiatives that identify people early on, and select those for specialist level care versus not. I mean, I think, this idea, at some point we have to say, you just can't call a palliative care team to come see everybody. Palliative care team should be seeing X, Y, or Z. So I think that's a key issue in terms of doing it. And then I think the third is obviously we've got to continue to build the specialty. And I think one of the, and I'm not sure about how it is in Australia, but at least in our institution and many places, this is an area that people really want to come into now. That we moved away from just care of the dying and life care. This is an area that's really attracting the best and the brightest because it gets rid of the cognitive dissonance. It's about taking care of people again and not taking care of organ systems. The communication skills that we teach, they resonate with them. It allows them to do things that, and allows them to handle situations that they felt powerless to do. And particularly for us, with jobs. I mean, as you said, there's demand, so people are actually getting jobs in here, so that helps.
We're having drinks and some nibbles next door, so if you want to ask Sean, can you stay please? Yeah, a little bit. Sean, ask Sean some more questions, and we're lucky enough to have you tomorrow for eggs that can solve, I'm sure, your brain, but I'd like to say it was a fabulous talk.
Thank you.
And we're privileged to have you and Diane here, and I think you guys have set the benchmark, and I don't know whether I'm excited or depressed because we've got so much work to do, because I just feel like we, and marrying that, I think I'm depressed because I'm thinking like with this, and then getting to the other end, those messages to the community is really important, and your marketing and your policy and stuff is just fabulous, and whoever you work with is just exciting, because every time we try and send a message, all we get is people holding hands or old people hugging each other, and trying to get this new message across to these marketing people is just really hard work here, and I'm just inspired by your key messages, and yourself and Diane have been fantastic, and I've learned a lot in the last 3 days, I'm sure all of us here have, so thank you very much.
Thank you.